Next, we'll hear about Landmark and Premera Blue Cross's collaboration in Washington State, and we're so pleased to have Adam Boehler, the CEO of Landmark, Dr. Michael Lee, Chief Medical Officer at Landmark, and Dr. John Espinola, the Executive Vice President of Healthcare Services at Premera. Adam?
Thank you. Appreciate it. So maybe to start, I'll just introduce who Landmark is and then turn it to John Espinola, Espy, as his nickname, to talk about Premera a little bit. So Landmark is the largest home-based medical group in the country. We have we're a risk-based medical group for about 45,000 complex chronic patients in 10 locations across the country. And our patients spread across product lines, so Medicare Advantage, Medicaid, dual, commercial, and exchange members. The commonality among all of our patients is they are very chronically ill. We, as I mentioned, are a risk-based medical group. We don't bill fee-for-service, and we're generally aligned on the three main things. Making a difference from a medical loss ratio perspective. That's largely done through avoidance of unnecessary institutional costs. From the perspective of patient satisfaction, and then quality. That's what we care about. Our care model is in-home primary care. On the medical side, we have a behavioral focus with psych NPs and psychiatrists, a social focus with social workers, and a fairly focused advanced palliative effort as well. We're a fully employed medical group, and I think a lot of our result in what we do is our clinical model combined with a focus on risk and all of those outcomes. So that focus on risk informs who we hire, how we train our clinicians, how we measure and compensate them, even our systems, our technology. We don't use an off-the-shelf EMR because we don't care about fee-for-service billing. We use our own an open source one and do a release every 3 to 4 weeks, really driving what we care about, which is total cost of care improvement, quality, and patient satisfaction. So that's us as a medical group. Let me turn it to Espy to talk a little bit about Premera.
Thanks, Adam. Appreciate that. And good afternoon, everybody. Really appreciate your time and a chance to talk about this collaboration that I think is making a real difference for our neediest members. First, before I get much further, I want to just provide a tidbit of detail about my background. I'm a physician who's in an executive role at a Blue plan, and I'm a geriatrician. And those two things matter because the way Premera sees itself in the world is pivoting more towards being relevant in the healthcare space, not just the healthcare coverage space. And when we think about that, our success is largely going to be driven by how we work with and through providers to achieve our objectives. And as a geriatrician, I have a strong bias in that direction and also a strong bias towards thinking about our frailest and neediest members. And that comes into play in just a minute in our conversation. The next slide that we're going to show here, I think, if I can advance, there we go, is just a little bit of background on Premera. We're a large regional Blue in the Pacific Northwest, where today it is sunny, for all those who are in other parts of the country and believe that it rains all the time. And we cover 2 big states, Alaska and Washington, and we're the largest commercial payer in both of those. We have a new business in Medicare Advantage as well. We've been in that now for 3 years, and we have a close collaboration with Landmark across both of these lines of business, commercial and Medicare. On this next slide, I want to frame up for all of you how we think about the problems in healthcare, and these are really driven by what we hear from our members. Our members always tell us over and over again, and this is whether it's an individual member or an employer customer, the problems are the same. They're paying too much for what they get. And that's because too often they don't get the care they need. Too often they get care that they do not need, and that can be harmful and, of course, wasteful. And too often their experience is less than they want or deserve as just human beings in the process. And for our sickest members, these problems are especially acute. They may not be mobile, they may be frail, they may have multiple touch points with the delivery system that are uncoordinated, and care may get lost in handoffs. And they often will have very complex communication needs that are unmet by brief episodic encounters with busy clinicians in the office. Another consequence of this is that they often have redundant, poorly coordinated care, and that can lead to waste and harm. And from an experience perspective, because a lot of these folks are not as mobile as they might hope to be, or because they're frail and sick and the burden associated with mobility is so great, their experience just really isn't that good. They're working with a system that is very provider-centric and not very patient-centric. And so for that, their experience is really suboptimal a lot of the time. And when we look at our sickest membership in Washington State, and we do an assessment of what the care delivery system can offer, we see that these folks have pretty limited options. There's been very little investment in home-based care models to serve these neediest patients. I know that from my own experience as a clinician working in this state for quite some time and doing that work. I was often the only one around in the community doing it. So when we were looking to serve these people better, we were seeking to do so with an innovative provider. And after working with those in the community in our network who didn't really have the ability to extend themselves into the community in this way, Landmark came our way, and from my perspective as a geriatrician and also based on the needs of our customers, it was an easy decision to make to partner with Landmark across both commercial and Medicare lines of business. Here you can see on this next slide a little bit about what our thinking was. Clearly, Adam's leadership as well as his clinical team, they have deep experience in this world and great passion around it. And the clinical model is a robust one. As you heard Dr. McGinnis say, these folks have complex needs, biopsychosocial model. There are other ways, other paradigms that people use to describe it. But the bottom line is considering all of their social environment, their financial needs, their cognitive status, their physical environment, all of these things are important when understanding how best to serve them. And of course, as Adam mentioned, the clinical model is grounded in focusing on results around quality, risk adjustment, and avoidable cost, and bringing the model to the patient, so an exceptionally patient-centric model. They've got the technology and scalability to do things that other providers can't do. And on the technology side, what I am always intrigued by is the fact that they are working to standardize the way they deliver care so it's consistent to ensure people do get the care they need from an assessment, screening, and treatment perspective. And they have the ability to grow because Adam is willing to invest in his organization with boots on the ground. You heard Adam mention about the way they work. They don't bill fee-for-service, so we had an ability to work with them to really carefully align incentives in a way that made sense so that we both win when the best thing and right thing is done for the patient. And what's very important when introducing a new provider like a Landmark to the community, when you're a health plan that has deep and long-standing relationships with your provider network, is you want to make sure you don't disrupt your network relationships. And Adam's team and our team worked very carefully to introduce Landmark to the community, establish expectations with our network providers about how communication would occur, how referrals could be made, and really establish boundaries around the role of Landmark versus the role of our network providers. In some cases, the network provider would retain primary care responsibility. In some cases, those providers would recognize that the best path forward was to let Landmark step into that role. But Landmark's flexibility around that was instrumental to us really encountering very little noise or disruption with our standing network. So those are some key factors that led us to choose. And Adam's going to talk a little more about Landmark itself and their experience, and then I'll come back and talk a little bit more about what we have seen over the past year and a half since we've implemented Landmark. Go ahead, Adam.
Thanks, Espy. Really the next slide talks overview of Landmark, and I won't repeat what I've said. I think that when I think about our success or factors for success in driving results, and again, ultimately, we judge our success on the basis of, significant reduction of unnecessary institutional spend, quality of our patients, both in terms of measures as well as in their lives, and satisfaction. Our belief is if we're able to delight our patients in a business model that works, then we've done something exceptional. The key for us, I think, has been being a fully employed group, being 24/7. About 15 to 20% of our visits are urgent visits that happen anytime in the middle of the night. And so that would be, a 94-year-old at 2 a.m. With flu-like symptoms. We'll go there, sit with her, stick and give fluids, IV fluids. And, the cost of that delivery is not cheap, but it's much better cost-wise and also quality-wise for that patient, for us to be there with her in the evening. I think so that's been key to us, and I'll talk through some of the results. The other thing has been the infrastructure. As I said, so important to us is our technology, our process, our training, our hiring, and our compensation methodology. It makes a big difference when everything is aligned toward one specific goal, and it lets us really drive performance in those areas. In terms of patients, what we do, we take risk over relatively long periods, 5-6 year periods. We take longitudinal risk. And you may imagine the patients we're looking for where we can make a difference are not going to get better. And in a way, it's a matter of time in terms of what will happen eventually. Every patient that we see is sick enough where it's worthwhile investing in a number of visits, getting them to know our 24/7 capability, documenting them, and being with them. The key then is how do you optimize your clinical resources in the short term? And for us, since we're seeing patients actively, the short term is the next 30 to 90 days, is in the immediate. And what we do there is we have a proprietary model to tell us likelihood of hospitalization in the next 90 days. That's on the basis of claims data, pharmacy data, and our own EMR data. And then we also bring in our own, we call them HFAs or human factor assessments, to judge the clinical acuity in the immediate term, and that will determine the stream at that given moment in terms of how often and what resources are allocated. That combination of kind of a longitudinal approach and then in the short term, a focused clinical approach, I think has made a significant difference. And instead of having patients coming in and out, they're always in because this patient base, as I said, is a matter of time. They're very sick. But we don't spread resources like peanut butter across them. We optimize within there based on the immediate need at that given time. I think that's been important. Shifting to the next slide, it shows you a little bit of a picture of what Landmark looks like today. And I'll see if it's not shifting on my screen. I'll hit it again. But it will show you, there we go. I hope I didn't go too far. Maybe mine's slow. It will show you a map of what we look like. Let's see, I'm not sure that's popping. Can you guys see, are you able to see slide 6? Maybe it's not hitting. Can you see that?
I can see it.
Okay, good. Maybe it's just not updating on my screen. That's okay. So in slide 6, you can see our footprint today. It's actually an old slide. I'm just recognizing, looking at it today. We're now over 100,000 visits. Some of it says Central PA launching. That's launched. But it gives you a picture of us today and where we are, generally we're looking to partner in areas where there's some level of density of complex chronic patients. Now, it doesn't need to be a major metro area. Albany, New York is not exactly, I don't know what tier city that is. I'm from there, so I'm allowed to say things like that about them. But just having some level within an hour's drive time is important. The other thing that's been important in our expansion here, and SB alluded to this, has been our partnership model with PCPs and market. We have not found necessary or helpful to push somebody out of a relationship with their PCP. That's usually not the issue. The issue is that office-based infrastructure doesn't have the ability or time, really, to spend with this patient base. And I will also say, beyond that, folks don't take care of themselves as much as they should, or else we'd all be a lot healthier. And in this patient base, they're not going to come into the doctor's office 15 to 20 times a year because they just don't do that. And so I'd liken it a bit like a trainer. If you're working out, you work out a lot more if somebody comes to you. This is a population that's well worth bringing care directly to them at any time. And so the nice aspect, obviously, is concierge care when they need it for free. If you look at the next slide, it's just a picture of our technology. I won't dwell because of time much on that, but it is custom developed specifically for what we do, and it lets us, because we have control, really push things out. And I'll give you a quick example, which is if we notice in market that hospice referrals are down or that they're not happening, and this is actually a real example where we said, okay, if we don't have an end-of-life conversation by the second visit, you can't close out the clinical record or you need an explanation. It lets us then see who's having those discussions and whether there really are advanced directives being established, and if some folks are not. And a lot of times that would let us zoom in and say, okay, these doctors in market aren't having those discussions. Why? Are they not comfortable having them? Is it not appropriate clinically? And that let us start to look and see who's doing, who's not, and have those conversations. So the ability to have that flexibility to identify there's a sub-metric that's just not adding up here, and then how it affects quality and admissions is an important one for us, and why we have our technology. Imagine Technologies is the name of our subsidiary that does it. The next slide, I'll actually turn to Dr. Lee, comment a little bit about results across the country, which has started to become fairly uniform as we reach maturity in our markets. So let me turn it to you, Dr. Lee.
Thank you, Adam. Hi, everyone. I'm Mike Lee. I'm the Chief Medical Officer of Landmark, and just wanted to state that Landmark isn't just about doing house calls, but they have a very strong bent towards performing interventions and very intensive services in the home to really stabilize these patients in place and allow them to stay in their place of residence. As Adam had said, about 15 to 20% of patients do call us for unscheduled urgent visits, and we're able to go out to the home 24/7 in person with a doc or NP or PA and really be able to do very meaningful interventions such as checking blood work, starting IVs, giving Lasix, Rocephin, Solumedrol, inserting catheters and the like. And just to be able to illustrate that, just wanted to share a story about a patient in one of our early markets. A 75-year-old male who had a history of metastatic lung cancer who's on chemotherapy, who 3 months prior to Landmark engaging with him had abdominal pain and actually was seen in the hospital for that with abdominal pain, nausea, and vomiting, and was admitted for observation, but unfortunately caught a hospital-acquired infection and ended up spending almost a month in the hospital and the nursing home before coming back to the home, and just completely wiped him out. After Landmark engaged the patient, we got the very same sort of symptoms, but the difference was that we were able to check the labs there in the home, and his white count was normal, and his labs didn't show any sort of obstructive pattern, but he was dehydrated. So we placed an IV there. We hung a bag of saline. He had pain, and so we aggressively treated his pain symptoms and his nausea and vomiting, and he was able to stay in the home. Now, what we also realized after spending more time with him was that no one had really spent significant time discussing advanced care planning with him despite his advanced cancer stage. And in talking to him, his real goal was to be able to stay at home because his granddaughter came by and visited him every day after preschool, and that was the highlight of his day. And so, in accordance with his goals, we really, focused on keeping him at home, and we ultimately were able to talk to him about palliative and hospice care, and he was able to transition to more supportive care and passed away in the home without any further hospitalizations, really in accordance with his goals. And so that's really kind of a bit of the essence of the Landmark model. And the slide that Adam's showing talks to some of our experience in terms of our impact on admissions. And in our most mature markets in upstate New York, where we have over 2 years of experience, what we're seeing is that by being able to do these urgent interventions, but also being able to, after you get your arms around them and educate them on health literacy and educate the caregivers, really being proactive about preventing hospitalizations, you can see that with tenure, we, on our engaged population, we're having an impact, 30, 40, 50% reduction from the baseline in terms of admits per 1,000. So, very significant because for this population, if they're admitted a couple times a year, their risk of mortality increases dramatically. And so you can see that, there's a big impact by being very proactive and very interventional in the home for these patients on admissions. So the next slide talks a bit to our impact on medical loss ratio. And you can imagine these patients are very high cost, often over 100% medical loss ratio for patients that are with, 6, 7 chronic conditions. And what we've seen over time is that through the impact of our impact on admissions, plus we're in the home, we're able to capture accurately the diagnoses and all of the HCCs that are appropriately there in the charting, that we've been able to drive significant impact on medical loss ratio. And so these patients who historically have been, well over 100% in terms of medical loss ratio are down into, over a span of a couple of years, down into the 70s in terms of medical loss ratio. So it's a significant impact in terms of not just, the admissions, but also, the revenue impact.
And, this population, as some folks may know, if you look at it, typically when we're taking risk, because risk adjustment kind of breaks down at the very high end, and my belief for why that happens is because the risk adjustment model in Medicare is a prospective model versus a concurrent model. And when you have more deterioration quickly, things that are based on last year don't quite catch up. And so very unusual for us in any medical group or payer that we work with to see anybody under 100%. If we were under normal risk adjustment, if things were normalized in a concurrent model, we've looked at that, we'd be running in the 50s to low 60s. But we're very happy because what I would say is when we initially partner with plans, one of their concerns is attracting poor risk, possibly, right? And as we move to a portion where you're under 100%, plans are much more flexible and able to really actually market this as a benefit where they otherwise may not. And so I think that's been very helpful. Oh, next slide, sorry.
And also, on the next slide, one of the areas that we feel really proud about is being able to have a significant impact on quality for the patient population. And so you can imagine for a very polychronic population, it's much harder to control, for some of the control measures and maintain compliance for them. But this slide talks to a composite of some of the quality metrics that our health plans ask us to focus on in our mature markets, and they typically would set a goal which is 5 to 10% above the baseline of what that population was historically doing. And you can see that across the board, and especially for the control measures, we far surpassed this already improved goal for this population, and we're able to hit 5-star metrics for the goal, for the targets that our health plans had. So, significant impact not just on utilization, but also improving patient quality scores as also. And going on to the next slide, obviously, this is essentially concierge-level care brought to the home 24/7, not for patients who can afford it, but those patients who actually really need it the most. And this slide talks to the results of a third-party survey that's done for patients, and a couple of things that really stand out. Obviously, it's a program where we're there when they need them, and so very, very highly satisfied. And the patient response rate for a mailed survey was over 50% of patients actually returned the survey, and actually in our most mature markets, it was a 76% rate of patients returning in the survey, so outstanding stickiness. And the Net Promoter Score of 93% is also, we feel, also very tremendous, in that the patients really see the value, and when asked, do they think that the Landmark program helped them to avoid a hospitalization or ER visit, vast majority, 97%, said that they believe that this did. So again, a very satisfied patient population. And just one other thing that I'll add is that when we look overall, one of the other sort of quality scores that we're happy about is that when we look at mortality rate for the population, I think by keeping these patients out of the hospital and from revolving back and forth in and out of the hospital, and giving them all of their options as their disease progresses, we've seen a significant decrease in mortality rate for the patient population, on the order of 15 to 20% decrease in mortality rate, depending on the market. So again, I think we're proud that patients are living longer with higher quality scores at lower cost, but also just a very satisfied population.
Let me turn it now to Aspi.
Okay, and I'll just wrap up real quick because I know we got to get back on track here. So you heard some of the results from a numerical perspective. I thought I would share a little bit from a health plan perspective about our experience working with Landmark and give a little bit of insight into how it works. Really, this is a very close collaboration. Premera is doing a lot of the analytical work to identify our highest risk members, developing that algorithm and methodology in collaboration with Landmark. Once identified, our members are notified of their eligibility, and our clinical team will even reach out to them, especially those members who are actively engaged with our case management team. And that helps prime the pump for receptivity, so that when Landmark reaches out, that member is not surprised, they're not confused, they understand what Landmark's role is, and helps increase the level of engagement. What we have seen so far is that the adoption rate is quite high. There are some people who will say not now, maybe later, but for the most part we're seeing much higher than expected engagement rates, and then for those who do engage, they stay engaged. We're also seeing good coordination of care across the behavioral health and other domains of care that are required to serve these folks. They have complex needs that are not served by only one clinician. It's usually important to engage others. And also our Premera's clinical team engaged in case management will also help coordinate social and community services to complement what's going on. Very importantly, what we see is, and Dr. Lee mentioned this, the members love the program. So as much as it's helping with their clinical status, it's importantly helping with their psychosocial status as well, knowing that they have someone that they can rely on and depend on, knowing that they have an ally who's there when they need them on their terms. And that's a pretty transformative thing in healthcare today. So that's one of the key things we really appreciate about it. We are seeing favorable impact on the Medicare side. We see essentially a budget-neutral impact on the commercial side. So we do invest in this, and it does cover the investment. We're not yet seeing ROI on the commercial side, but that doesn't mean that we would make a change. It's a different population and a little harder to get at than the Medicare side. And I think in the interest of time, I'm going to leave it at that and allow Claire to get her presentation underway.